Okay. Alrighty, and so it is my great pleasure to introduce our next presenter, Dr. Christopher Gabriels. Dr. Gabriels has been practicing eye care in Albany since completion of his ophthalmology residency at New York Medical College in 1999. He joins his father's practice and has been managing glaucoma as well as many other eye conditions and performs cataract, LASIK, glaucoma, and oculoplastic surgery. He is the third generation of Gabriels ophthalmologists in Albany, which started with Dr. Joseph Gabriels in the early 1900s. Okay, Dr. Gabriels, it's up to you.
Okay, hello everybody. Great to be here. It's a privilege to be asked to do something like this. Honored and privileged. Hopefully I'll do a decent job. I'm a little challenged with the information technology, but I'll do my best. What I'm going to be talking about today is basically glaucoma, the nuts and bolts. What I think most people want to know about it, for themselves, for their family members, for its effect on our whole society. And of course, I am getting some glare from my glasses, but maybe if I put my chin up in the air, my nose up in the air, but that's not the way I really am. But anyway, so I'm going to start with a slideshow. It kind of give me a way to kind of an outline rather than just talking off the cuff. Now I've got to find that I want to share, which I thought I had loaded here, but no, I don't see it as fate would have it. I had it up on Chrome and I don't know where it went. If you give me a moment, maybe I get it up again and that'll make this nicer. So there it is. Now,
See the share screen at the bottom? At the very bottom of your screen, if you move the cursor, there should be a green share screen button. When you click on that, it'll give you a number of options.
yeah, rats. Giving me the option here on the screen. Even though I've got it up. Boy, and I practiced and everything.
Sometimes you have to slide down on the right-hand side to see all of the things on your screen.
Yeah. Well,
It may be at the bottom.
So when you bring it up on your screen, can you see what it is you'd like to share? If you minimize the zoom, not exit out, but hit the little minus, it should take the zoom part off the screen for just a minute so you can bring up.
oh, there will be no slideshow because I've got it loaded here, right here. I don't know how to get it to screen share. It's probably just somehow it's got to be linked.
When you hit.
Well, so much for. Yeah, I
So
think I've got to give up there.
Okay, are you hitting the green arrow button or the caret? If you hit the green arrow button on the screen share. It's looking good.
New share.
Uh,
There it is.
we see a plain white screen. Is that what you were going for?
This is what I'm going for. Is it?
Oh, there it is. Perfect.
And it won't just. There we go. So can people see that?
Yes. Yep. We see a eye
Okay.
close up with the word glaucoma
All right.
in the middle. Perfect.
All right. All right. Who knows? Maybe I'll salvage this thing for after all. All right. So back to the subject at hand. I'm supposed to talk about glaucoma, let you know about glaucoma. Basically, what glaucoma is a disease of the optic nerve. Not everybody understands that glaucoma as a problem related to eye pressure. Eye pressure has we can control to try to stop it.
I think I'm winning because I have
Pressure on the optic nerve that ultimately what causes vision loss. And the is kind of like high blood pressure. No, you have it, and it's doing damage, even though you don't. To get to the eye doctor and let us check look at your optic nerve, check your peripheral vision, the anatomy of your eye, to make sure you have or don't need to be at least watched to have it. We've got a lot of what we call glaucoma suspects out there. All right, well, it's not loading too well, perhaps. All right. I don't know what people can see right now.
We're seeing the screen, the normal eye, glaucoma, primary open angle glaucoma.
Okay, well, maybe we just taking a while to download properly. All right, well, hopefully it's downloaded now, and now it can go a little more smoothly. It'd be nice if I could see myself and the slides, but I don't think I'm going to get that. That's for sure. So back to glaucoma again. There's really many different types. The one we're always most concerned, so to speak, is the primary open angle. It's one where you don't have any symptoms for. And about 85% of glaucoma that we see and treat in the United States is primary open angle. And I'll explain a little bit about that in a moment or two as well. Angle closure is yet another form, has to do with the anatomy of the eye. Congenital just means you're born with defects in the structure and the anatomy of the eye that cause high eye pressure. Secondary means your pressure usually is up because of some other problem with the eye or the body. Pigmentary is a specific glaucoma of the eye where pigment rubbed off the back of the iris and clogs up the drainage, causing high eye pressure. Fortunately, the hardest one to treat really, genital, is normal pressure or normal tension glaucoma. People come in, they've got the optic nerve changes, the peripheral vision changes, yet normal eye pressure. You only treat glaucoma one way. There's a lot of positions about how to otherwise protect the optic nerve, but The only way we treat it is lowering eye pressure. So if you're low or normal to begin with, it's hard to know what to do for you if you're already starting out with a low eye pressure. That's a challenge. So back to the primary one, the one we see most often, primary open angle. Now, what does open angle mean? Well, we've got this part of the front of the eye called the cornea, that window, and then that kind of turns into the sclera, the white part of the eye. Same collagen, it's just not in a laid down. It's and that's why it's white, which it should be. You don't want light from everywhere coming into the eye. Well, as some of you probably know, eyes includes the iris. That is the kind of the shutter, the aperture, the front of the eye to allow light in. If it's bright out, it gets small, the pupil and the iris. If it's very low lighting, our pupil tends to get bigger. And that controls that aperture. Well, that inserts into the side of the eye, obviously, and where that inserts into the side and where the cornea kind of turns white into the sclera, it's called the angle. And it goes all the way around the eye at the edge of the iris. And that's where fluid in the eye escapes or is put back into circulation, if you will. The fluid in the front of the eye is called the aqueous humor. It's got nutrient factors in it. It's got oxygen in it. And all those parts of the eye that can have blood vessels, like the cornea and the lens, are nutrified by clear fluid. So it circulates through. It's made behind the lens in the ciliary body, that little bump you can see behind the iris, if you can figure that out, the lens as depicted there. And it's got to go through the pupil and then circulates through the front of the eye and gets out that little angle there. Well, people have an open angle. The reason their pressure usually goes up is because that angle somehow becomes not as permeable. So if you're putting water in a closed space and you have the same rate going in as out, no problem. But if the obstruction out occurs, the pressure inside that system is going to go up anyway. So, open angle, no problem with the angle. Anatomically, it just doesn't siphon the fluid out as well. So as I explained, basically the tension or pressure in the eye goes up if the fluid can't escape the eye as quickly as it's put in. That causes the high eye pressure, which then causes the optic nerve to degenerate in a characteristic way. This is a little depiction of how vision is affected by glaucoma. It starts from the outside, usually not in such a generalized circular way, but little arcs are lost, which correspond to the anatomy, the nerve, the act. It all kind of fits, but unfortunately, degeneration is the one disease that ultimately can put you in a sea of darkness, as we say. Macular degeneration, at least you always have peripheral vision. People don't know you can't see, but you can't drive, watch TV, you can't read. You can walk around. Glaucoma is a thing if untreated and end stage. So there's not too many symptoms from open angle glaucoma, like I said. There are risk factors, African heritage, diabetes, nearsightedness or myopia, and ultimately age. Macular degeneration was the highest form of reason, I should say, for visual impairment in the United States. Well, the older our population gets, things change. Glaucoma is now a leading cause of visual impairment, both correctable, and uncorrectable in the United States right now. Interesting. This is a disease we could do more about than macular degeneration. So that's why it's really key to get the diagnosis and get treated. Angle closure, I was talking all about that angle anatomy where the iris comes into the side of the eye and cornea meet. Well, some people have an iris that is bowed forward or thick at the periphery, and that angle becomes obstructed. If it happens slowly, we call it chronic narrow angle glaucoma. And again, the symptoms can be subtle, but people, when it's dark, may dilate a little bit and it cause more of an obstruction there, and their pressure will go up high enough in a short amount of time where they'll get symptoms of halos and pain. If it happens all at once, where the whole angle kind of zips shut, and that happens, it's called acute angle closure glaucoma. And that's a rough one because it's very painful and gets blurry very quickly, visible, usually by putting a small opening in the side of the iris for fluid to get through. But that's under treatment. So we'll just continue on here. Again, the same basic risk factors as the primary open angle. About 10% of angle or glaucoma is from acute, or chronic or acute angle closure. But that's that's an anatomical problem that can be fixed surgically many times, usually with a laser. Congenital, we won't talk too much about this. Again, all kinds of different things can happen in the development of the eye in fetal and embryonic stages, just a part of the body. But certain of these malformations cause glaucoma or high eye pressure, usually because the drainage angle is obstructed. It's a little different about infants. When they have high eye pressure, their eyes get big. The pressure actually causes the eye to stretch and get bigger. I think there's one photo here. Yeah, we call this buphthalmus. And you can see the left eye is really prominent. He's probably got some in the right eye as well, but there are more extreme examples, but I don't need to show you these pictures necessarily. You get the idea. Yeah, they rub it a lot because they can't complain. They rub their eyes, and they're very photosensitive, sensitive to light. Usually in this day and age in our country, we can die. And unfortunately, it's still very hard to treat and prevent impairment. So this only is. All right, some of the symptoms of the type. You don't have to go through the details, but what do you do with that outflow? Secondary glaucoma. That's glaucoma that's caused by another condition or a systemic condition. Uveitis is things to kind of stick together, and obviously where you have and sticking to the side of the cornea and blocking it, that happens a lot. Cataracts sometimes cause it to get larger, and sometimes that causes the bowing tortoise and an angle closure type of glaucoma. May can impair outflow. Trauma include a lot of red blood cells or hemorrhage in the eye. The front of the eye where that circulating fluid is can cause high eye pressure. Pigmentary is a subset of open angle glaucoma. This back of the iris where all the pigments are is kind of rubbed by those little zonules or things that hold the lens in place. So once they're circulated into that aqueous fluid and go through the pupil and then try to drain out through that meshwork or that angle, it kind of gums it up and the pressure goes up. Normal tension, again, a bigger problem because the only way we know to stop glaucoma and stop the peripheral vision and, God forbid, the central vision loss by lowering eye pressure. which doesn't always work anyway. But if you're starting out with a lower normal pressure anyway, it's more difficult. And many times will lead to a surgical procedure to lower the eye pressure. Diagnosis, well, obviously get an eye exam. We check everybody's eye pressure. Optometrists who do comprehensive exams, as well as ophthalmologists like myself. Gonioscopy is a way to look at that drainage angle, which we can't do directly with our microscopes. But if we put a lens on the eye with mirrors, we can see how the iris inserts into the side of the eye, where the cornea comes in, and how open that angle is, or whether there's a lot of pigment in it. Stay of diagnosis is perimetry or peripheral vision testing. Everybody's favorite test. I've been worked up for glaucoma out there. You're probably smiling or rolling your eyes right now. Nobody likes these tests. They're tedious and boring. And if you have a really dominant eye, the non-dominant just kind of blacks out once in a while. It's nerve-wracking because you're under pressure to do it right, so you're not misdiagnosed. But it's very helpful to us. We used to have something called a Goldman perimetry, where a technician actually moved things around. There are different ways to measure peripheral vision, but right now that's the automated perimetry, where the technician plugs the numbers in the chair, puts a pirate pad on an eye, and comes and flips it in the other eyes, probably what 99% of us ophthalmologists do, to track and glaucoma or rule it out. And my technical problems here. All right, photography of the optic nerve. So that is just kind of, they're a little bit skewed pictures of the optic nerve. That actually we have depth perception. Our eyes aren't perfectly lined up all the time, and that's how we get a of depth. Well, we try to see how that optic nerve looks, because or is cupping of that nerve, or pouring out or excavation of the middle of it. The cup, the empty space. If that gets bigger and bigger, because the rim tissue, the actual neuroretinal rim, is getting thinner and thinner, that's the atrophy, that's the real comatose optic neuropathy that was associated with the visual loss. Again, usually caused by higher eye pressures than that particular eye can tolerate. How do we treat it? Well, eye drops, lasers, and surgery. I read a few articles recently. There's a laser we do sometimes instead of the eye drops. Open angle glaucoma and pigmentary glaucoma. It basically applies light laser energy to that meshwork in the angle, and probably through a little minor inflammatory response causes increased outflow. That's why everybody's a little sore after what we call an SLT, selective laser trabeculoplasty, or the old-fashioned anterior laser trabeculoplasty, ALT, or argon laser. There's more of a push for that now because you get better compliance, obviously, than drops. But drops are still the mainstay. Probably 85% first-line therapy is with eye drop, lower the eye pressure, and there are many types. Well, no. All right, I'll just stop the slideshow now, just so I can, you can see my happy little face, I think, if I can do that. You are screen sharing. How can I get off this? And on me.
So that when you move the cursor, you'll get a box.
Stop share.
Stop share.
Stop that sharing. All right. I'm not sharing anymore. Okay. Hope it's not too dry. You know, you're just hearing a voice and trying to work through those slides. Like looking at Jonathan, there's one smiling face. It's a static smiling face. How you doing, John?
Great.
So glaucoma is a big problem, and it's maybe the biggest, bigger than macular degeneration the older we get, because the thing I always say to my patients is, well, I'll live to 130. We're all going to have some macular degeneration. We're all going to have some glaucoma. The difference between this is our lifestyle and our other risk factors and our DNA, basically. So anything else, things, you know, wear out. And our eyes, the machinery in our retinas wear out. It's macular degeneration with abnormal responses of the body that grow abnormal blood vessels that leak. And Dr. Huz, if he didn't say that already, go before me, he'll tell you after. And glaucoma, which the machinery, the eye just can't maintain that nice low pressure and circulate that purifying fluid. And the pressure goes up, and the optic nerve is vulnerable to that by degenerating in that characteristic glaucomatous way. So get to your at least once a year if you're over 60. Make sure you don't have it. If you have other risk factors, again, African American, family history, good to get in there and just get somebody to make sure your optic nerve is suspicious and your eye pressure is not high. And if either of those are true, get one of those peripheral vision tests to make sure you're not losing peripheral vision that you don't know is occurring. So I don't know what the time frame is. I'm probably pretty close to maybe a question and answer now. If I've stimulated any interest here.
Well, you've definitely been very informative. So some of the questions I was going to ask, you've already covered magnificently. Thank you. And we do have time. We have about like 20 minutes for questions. So if any of our participants would like to raise their hand on their screen, they can either click on the participants option at the very bottom of their screen and raise their hand, and I will call on you in that order, or you can type your questions in the chat. If you have called in and you're on the phone and you would like to raise your hand, just type in *9. We'll do that. But at this point, if we're not having a rush on questions, so if you're on the phone, you can *mute. We do have one from Laura. What is a scan B to check why pressure is high? What is a scan B to check why pressure is high?
I understand that.
Okay,
I got it.
perfect.
A Bscan is basically an ultrasound. Thank you very much. Usually reserved for eyes almost exclusively where you can't see beyond the lens, either because they've got an end-stage cataract or some other inflammatory condition. And the only way to visualize at least the surface of the back of the eye, the retina and the optic nerve, is with an ultrasound. A-scan is different. We use A-scan to measure the length of the eye for workup for an implant measurement and the anatomy in the front of the eye. Mostly we can see, but A-scans have really come a long way, and we can see things the way that iris and lens come together and where that iris fits into the side of the eye with an A-scan. But the B-scan is specifically for getting some idea what the anatomy, the back of the eye looks like when you can't see it. And it's ultrasound, basically. If you can, that's sophisticated enough now where they can actually maybe see cupping of the optic nerve with that. Usually it was just to make sure there wasn't a retinal detachment or a big hemorrhage because it wasn't very refined. But now, you know, you can see the real contours of tissue now with the technology we have. So I use too often, you don't hear glaucoma specialists talking about Bscans too often. It's usually the retina guys, but it's useful more and more in this capacity. Right.
Great.
Helen, how you doing?
I had a sudden change in my vision in the last several months, and I find that I'm a little shaky emotionally because of the sudden change. I was driving until July, and then I stopped driving, and so I don't know if you have any words of encouragement to use as I find myself transitioning, if you will, to this new aspect of my life. And I did have the low vision exam with Dr. Casey Gee. Anyhow, I have both AMD, dry, and glaucoma. I've had glaucoma for a long time, and then developed the AMD, and then pretty suddenly things changed a lot. Thank you.
Yeah, well, glaucoma's hard enough. But at least you really kind of don't, unless it's advanced severe stage, at least you don't know what's happening. These little pieces of your peripheral vision are going away, but they're not black areas that you can detect. They're just missing. If you, but it's quite a strange phenomenon. We have a test screen where a little round circle 3 or 1 meter is passed. And even us normally, we have a physiologic blind spot where our optic nerve comes into our eye. There's no photoreceptors there. So you throw an eye and you've got this black screen, you move this, it disappears. And then it comes back. And you're like, how is that? It's like the seeing parts just come together and now the non-seeing disappear, but not where you can detect it. So we never know. But boy, once if that's going on, and then boom, your central vision gets hit with macular degeneration, that's tough, because that's the thing that immediately impacts your life. Like I said, people with moderate or progressive dry or wet macular degeneration, it's in both eyes. You can't see a face, you can't read, you can't drive safely. Watch TV. Let's face it, we all watch TV. We're all looking at monitors here. So that really impacts your life in a devastating and fast way. If you've got it in one eye already, and then boom, it hits the other eye. So I feel for you, Alan. It is a rough thing. Work with the low vision specialist, and bet you can. And of course, the doctors we'll use whatever technology we can for the macular degeneration to keep that and the glaucoma in check as much as possible. Hang in there.
Thank you.
You're welcome.
Ellen, we do have social workers at NABA who specifically work with people transitioning through the emotional part of vision loss. So we'll have more information on that a little later today, and you're welcome to call the office and ask about that after today.
Yeah, well, I do know about that because I was told about that.
Okay, wonderful.
Yeah, thank you.
Thank you for participating today. Doctor, we do have a few more questions actually in the box, and we have about 10 more minutes to answer. So
Great.
One participant asks, I have been using timolol drops for years for early glaucoma. Do you recommend any type of drops to counteract the effect of the dryness and burning that comes from the timolol?
Yeah, that's the problem with eye drops is side effects. Some are local, the eyeball itself. Beta blockers in particular, of which one timolol is one, actually use the same medications to prevent heart attacks and lower blood pressure. Lopressor or metoprolol is a beta blocker. A lot of people are on that. In the eyeball, when absorbed, it decreases what we call aqueous production, that circulating fluid in the front of the eye that neutralifies the avascular portions. For some reason, it lowers that production, so it can lower eye pressure that way. That was the first real big breakthrough in drop therapy was beta blockers. Now, again, eye drops and beta blockers, what I was getting to is can have systemic effects in the low absorption you get into your bloodstream of the timolol can be shown to have some systemic effects in some older people, especially with heart block. That's the big one. Can't give, or somebody with a bronchospasm or an asthma problem. You don't give a beta blocker; it constricts the airways. But the most common effects that people don't enjoy or have to deal with eye drops are local. You know, irritation, blurriness after they take them, a dry feeling, uncomfortable, redness. So fortunately, most of these, we've been able to decrease the amount of preservatives in these drops, which were mainly the culprits for the local side effects. But some people just don't tolerate drops very well in general. There's not, you know, if it's important to stay on the drop, then you stay on the drop. And what you're asking, what can we do to kind of alleviate those symptoms? Well, you know, there's nothing too specific about side effects from eye drops. Of course, it's a true hypersensitivity, then you can't take the drop anymore, no matter what. You know, you just have an allergic reaction, and the more you put in, the worse itching and redness all around your eye it becomes. For the kind of chronic side effects like that, you know, artificial tears, just don't take it right after the eye drop, or it'll wash the drop before the medicated drop out before it has a chance to be absorbed. Keeping the eyes closed for a period of time after you put the drop in. A lot of people who are on eye drops have other ocular surface conditions, the main one being blepharitis or oil or meibomian gland dysfunction, and don't have a normal tear film. They evaporate too quickly because of those oil glands being inflamed. So if you have a concomitant, you know, eye condition like that that's untreated, but otherwise not very symptomatic, it can turn it into a symptomatic problem like blepharitis or dry eye syndrome. So there's artificial tears, there's anti-inflammatory dry eye drops, Restasis, Cidra, a new one called Sequa. Again, you know, yet another eye drop, but they do treat inflammatory dry eye very well. I treat a lot of blepharitis because most of my patients are over 60 and they get that eyelid condition that causes the oil glands to produce not a sufficient quality or quantity of oil. So their tears evaporate quickly, and it can cause irritation, redness, dryness, itchiness. So I treat the eyelids with something called Nova spray is one. You spray it on the eye and just wipe it off. Eyelid scrubs. If people have bad rosacea, ocular rosacea, doxycycline, and fish oil, you know, as a supplement has been very, well, I'm getting my face right in there. You probably don't want to see that, everybody. Fish oil supplementation by, you know, was touted for a long time. It's a little controversial whether it really is the oil glands in the eyelid for this chronic blepharitis condition. If you're having trouble tolerating the timolol, if it's generic, it may have a lot of extra preservatives, differences in quality requirements for branded versus generic drops. So could be an avenue to look down. And you could also ask if you could be on try a different drop if you haven't already. There's a lot of different glaucoma drops now. One maybe you might tolerate better. But treating blepharitis if you have it, treating dry eye if you have it, may minimize those symptoms for you. I hope that helps.
Thank you. We've got a couple more questions like, are there warning signs of glaucoma and are there surgeries to help cure glaucoma?
Warning signs, like I said, the most type of glaucoma is primary open angle glaucoma, which rarely presents with symptoms. If you're coming in with symptoms, once in a while you get maybe halos or other kind of secondary symptoms. But unfortunately, if you're coming in with symptoms from glaucoma, primary open angle, narrow angle, you get symptoms because of pain and pressure goes up quick. Primary or any open angle glaucoma, not particularly the case. So you really don't have symptoms. If, gosh forbid, you start walking into the right side of every doorway, that means the glaucoma has progressed. And there used to be a theory of well, not used to be, but it was a snowball effect. The longer you have it, the harder it is to stop that snowball that's rolling down the hill, being bigger and bigger and bigger. So early detection and screening is the key. So symptoms, not surgery. Again, the only way with glaucoma, or try to stop its progression, we can never get back what we've lost from the optic nerve, but we can stop its progression. That's the key. And if we can't do it with drops or lasers, yes, we have to lower the eye pressure with basically a plumbing job, which used to be just a bleb. We make a little opening in the side of the cornea and put that, and make a little opening into the inside of the eye so fluid could drain out, and then put that conjunctival at the very loose tube over the white part of the eye over that and form a bleb, percolate out. Hard to control, hard to be, it's, you want it just low enough. It keeps the pressure at a nice safe range, hopefully, but not, and there is hypotension or hypotonicity where you make too big of a bleb, and the eye is like a balloon. You have to have some intrinsic pressure. If it's zero or atmospheric, everything starts to come apart. You need that intrinsic pressure to keep everything pasted up against the side, basically. So surgery is the last resort, and more often now we don't use trabeculectomies or blebs. They put in the ceton, which is basically a tube, and it goes into a little reservoir, which is covered with special collagen tissue, and then that conjunctiva over that. So you really don't see it, but then the fluid percolates slowly through those. They last a little longer than the blebs, which can scar down. But you never really cure glaucoma. I mean, if you have a good surgery and you get that pressure down where you want it, surgery eventually is going to fail. If it's 2 years or 5 years, 10 years, wow, that's a win-win. But sometimes, you need revisions and that sort of thing. But surgery can really take care of it for a good long while. Nothing really cures it though, per se.
And we've been getting a lot of thank yous in the chat for your helpful answers. There's one more question that we haven't. So do people who have glaucoma have an increase in light sensitivity as the disease progresses? Is the question.
Yeah, not particularly. It's getting towards end stage where you're losing more and more peripheral vision. You may be sensitive to different light conditions. Not so much, and too much light, yes, may be more impairing than somebody who doesn't have such constricted visual fields. Angle closure, absolutely. What happens is if you get, well, actually, if you get not enough light, the pupil tends to dilate, and that's when that pressure can go up because it bunches up the edge of that iris towards the angle and obstructs it temporarily. So, but again, that's with less light. People in movie theaters or driving at night tend to get symptoms from their angle closure. But bright light, if anything, constricts the pupil and doesn't cause angle closure to get any worse. And again, any type of glaucoma, if it's end stage, yeah, lighting can be irritative or impair the vision a little bit. But photophobia or light sensitivity is not a cardinal symptom, really.
So, Doctor, one of the questions, thank you for that. One of the questions I get asked often is if someone is already blind that they can't see, can they still get glaucoma? And so would somebody who cannot see, do they still need to go to the eye doctor every year?
What's the first part of the question?
So if someone's blind and they can't see, can they still get glaucoma? Would they still need to go to the eye doctor every year?
That's a good question. I mean, obviously it depends on your level of visual impairment, but anybody can get glaucoma, and somebody who's already blind probably has a ton of risk factors anatomically for glaucoma. So if your vision is already limited by some other condition, many times, yeah, glaucoma is a concomitant condition, either anatomically caused or associated with abnormal function and anatomy, or you're at risk for higher eye pressure. So, yeah, don't ignore what vision you have left. That's for sure. Make sure you keep getting it monitored because you want to keep what you have.
Great, thank you. So you mentioned earlier that trauma years previous can cause glaucoma or be a contributing factor, I understand, later on. So when you talk about, does that mean like kids on the soccer field sustaining a head injury, like a concussion? Is that the kind of trauma that somebody would need to be cognizant of having received to keep an eye out in years to come?
Previous eye trauma that doesn't necessarily cause immediate visual impairment usually won't have any long-term sequelae, we call it, or risk for glaucoma, but it can. There's something called angle recession or cyclodialysis. Basically, what happens is that angle where that iris comes into the side of the eye is torn a little bit, and their pressure may not go up initially, but years later, look at one of those little gonio prisms I said, we put the mirror lens on the eye, and we can detect an abnormality, which may not manifest until later on. And trauma can cause a lot of pigment dispersion, which may not initially cause the pressure to go up, but a lot of that liberated pigment from the blunt force trauma being released into that aqueous, which eventually gets deposited in that angle and that meshwork, yeah, may not cause an initial increase in pressure, but may down the road. So it's certainly possible if you've got, it's not like a concussion syndrome where years later something like that is going to suddenly rear its head. No pun intended. There's not too many things that years down the road trauma will be one of the risk factors or culprit for leading to a glaucoma problem. I mean, if you're what'll happen to kids on the soccer field, they'll get bopped. It'll get right square in the eyeball, squish a little bit a second, and they get an iritis and a hyphema, which is an inflammation and a bleeding in the front of the eye. And again, that's where it may tear a little bit, and they're usually managed very closely We used to take them in the hospital with an eye patch, even before I was an eye resident. But they just need to be watched closely. If you've had eye trauma, even if it's not something that was terrible at the time, it's always a good idea to stay, at least every 5 years, every 3 years until you're in your late 50s, 60s for a yearly or annual exam. But per se, not too much from trauma. It's going to happen right away with glaucoma if it's glaucoma related, usually.
Okay, great. We still have about 5 more minutes for any questions for Dr. Gabriels. Please feel free to share it in the chat.
And I'm not being rude.
No
I
worries.
had these funny little memes and things I was going to share, but I don't dare mess with the screen right now, I'll tell you that.
No, me neither.
So I'm just, I might end up just holding them up to the camera if we had a moment or two. I'm not much of a lecturer, but yeah, you try to start out with a joke, if I only didn't wait till the last minute, it'd probably been different. Or maybe not.
Maybe not. So, okay. But so regular life, day in, day out things like rubbing your eyes, a couple people brought up like dry eye, that kind of a thing. You can't, oh, I know what the other question is when you have glaucoma, does it happen in both eyes or can it only happen in one eye and not the other?
That's a great question, Lisa. And most of the time, the primary open angle glaucoma, the common one, 80% plus, will progress in an asymmetric or different, at a different pace. Usually you'll end up with glaucoma in the fellow eye once diagnosed with the primary eye, but they rarely happen at the same rate. But yeah, the other eye is usually always at risk, and eventually, again, God willing, you live long enough, you'll start to show some cupping and some glaucomatous vision loss and peripheral vision tests in the fellow eye as time goes on. What it's really poignant or pertinent to that question is when one eye is really progressing, high pressure, can't control it, and the other eye just seems fine. That's when you have to start looking on primary open angle and looking for a secondary cause, meaning a different condition of the eye anatomy or a systemic condition. Sometimes venous pressure on that side of the head will decrease absorption of that aqueous fluid back into the venous part of the bloodstream where ultimately it goes. So yeah, if something is very asymmetric, you have to look elsewhere for other things. And you can make a life-saving diagnosis doing that at times by imaging the carotids or the vascular anatomy of the neck and the head for an asymmetric case of glaucoma. Or of course, anatomically, there could be an abnormality with the other parts of the eye that have to do with the fluid circulation. But usually they're gonna, if it's the generic primary open angle, not the same rate, but eventually a bilateral, almost always,
Okay.
by rule.
Great. Well, I on behalf of NABA and myself personally, I would like to thank you very
But that was fun. Oh, you can see that, can you?
Yes, I like that one. I saw that one earlier.
Yeah, that's a good one.
Well, thank you so much for joining us today. I hope you can stick around for some of the other presentations today. But thank you so much for coming and sharing your expertise. If ever anyone needs to get a hold of Dr. Gabriels, whether it be for a checkup or what have you, he is at Gabriels IMDs at 960 Western Avenue in Albany. The number to call to make an appointment is 518-482-4459. And that's Dr. Christopher Gabriels at Gabriels IMDs, 3 generations of eye care in Albany. Thank you, doctor.
First Zoom meeting ever, right?
Exactly.
Thank you very much. I know I lost a little bit of the audience at the beginning. I apologize for that, but hopefully it all worked out, and hopefully I imparted some knowledge and made it tolerable, at least for the last
Your
40
presentation
minutes or
was
so. Thank you so
spectacular.
much.
Nope, your presentation
Oh,
was
thanks.
wonderful, and we covered at the beginning how while all of us are professionals in our own right, there's not a professional videographer or tech person for videos on
I
this call.
almost ended up swinging it.
Yeah.
Just took another minute. So
Yep.
yeah, I'll probably stop it, and then now when I rejoin, I'll just be part of the audience, right?
Yeah. So what I'm going to do